Ready?
So good evening and very warm welcome to all of you. And on behalf of Ahmedabad Orthopedics Society and the Gujarat Orthopedic Association, so it is my privilege to extend a heartfelt welcome to each one of you. So we are especially honored to welcome our esteemed faculties who have joined us from USA, and a very special note of thanks to our beloved Sheetal Parikh for his remarkable efforts in organizing this event. So I would like to invite Dr. Sheetal Bhai to deliver his talk. So welcome to all of you.
Thank you, Kamlesh, and welcome everyone. Thanks to Ahmedabad Orthopedics Society for organizing this EME at short notice. And we have a bunch of lectures that are lined up. I'll start with fractures around the knee. We do have some other faculty who are going to join us shortly. And we have Taral Nanda as well from Mumbai, who's going to share his views on supracondylar fractures. So we'll get started with knee fractures. So fractures of the knee in children, we looked at the claims or medical negligence claims, and there were 13 cases of malpractice. 6 of them were missed. Either spine fracture, 1 orbital artery injury was missed, secondary intermediate femoral condylar fractures, and others were cast and post-op complications. You can see that a lot of things can go wrong if you don't analyze the patient and the imaging appropriately. These are the list of cases that I'm going to show. So this is not a dynamic talk. Nowadays, you can get all the dynamics from your social media platforms, including Orthopedics and a lot of online articles. So we'll just look at cases, and then we're going to discuss some of the complications or what can go wrong. Because that's the focus of my talk, is just to look at complications. We start with Pfizer fractures. So there are principles of treatment based on what type of saltatoric fracture we identify on the X-rays. So here are the examples of type 1 and 2, which are extraarticular Pfizer injuries. And these are treated in a cast if they are not displaced. If they are displaced, they are closely reduced and fixed. When it comes to type 3 and 4, these are intraarticular fractures. We would recommend CT scan for intraarticular fractures around the knee. If they are not displaced, they can be treated in a cast. But if they are displaced or they are displaced and then reduced, we would recommend doing fixation for these fractures. we look at the shape of the physis of the distal femur, it's undulating, which means that whenever there is a fracture, there's a high chance of having a growth arrest. If you look at the rate of growth disturbances after the physeal injuries around the femur, it's very high. It's almost 50% of the patient would have a growth arrest rate. So the displaced fractures have high rates of growth arrest compared to undisplaced fractures. And Salter 1 has higher rate than Salter 4 has higher rates than Salter 1, which is intraarticular fractures have a higher rate of growth disturbances compared to extraarticular fractures. So let's look at an example. This is a Salter 1 fracture, 10-year-old female. It's a displaced fracture, you can see. I will just make this a little bit more interactive. So I'm going to ask some of our residents to see or to get their views what they would do if they have this fracture in the emergency room. So any ideas of what we're looking at? I want to give you a hint by saying the neurovascular examination is intact. Does that mean that these fractures are more prone to vascular injuries? What are the ideas? Who are the first few residents? First few residents? Okay. What are your concerns when you see this injury? Yeah, neurovascular complications, that's correct.
Anything might you can say.
Anything else? What would you do for this patient?
Nose reduction.
Nose reduction. And if you get a really good anatomic reduction in the ED and the patient neurovascular examination is intact, what are your next steps? Would you admit the patient for observation? Would you send them home or would you still fix it? You can answer. If you have an anatomic reduction of this fracture, would you treat the patient in a splint or a cast, or would you fix it? Third year? Fellow?
Let's get on to junior consultants. Let's get on to junior consultants.
So I'll tell you. Even if you get an anatomic reduction, these fractures, because even if there is micromotion, they will lead to growth arrest. So these fractures are always fixed. Okay? Even if you get a close reduction, 100%, they need to be fixed. All right. So remember for distal femur. So typically you can fix with the different ways, but typically we use cross K wires to fix this, smooth K wires, so that we don't damage the physis anymore. So you can see it's an anatomic reduction, 2 K wires, and these fractures heal really fast, 3 to 4 weeks, and they will heal. So there are different configurations of how you can put the pins, but basically you pin them and then you can remove the pins in about 3 or 4 weeks. Okay? So this patient, the more important thing is to follow this patient because of high growth arrest. So this patient, you can see the physis, there is complete growth arrest, and you typically would do some CT or MRI or high imaging to look at the extent of the growth arrest. But here you don't even need a high imaging. This is a complete growth arrest. So you would have to deal with all the effects of the growth arrest. You may bend the patient, you may do an exegesis on the other side, but some form of limb equalization would be required if there is a deformity and correcting the deformity. I'll move on to another case, a 13-year-old boy who fell off a bike. Can anyone try to classify this fracture? We looked at the Salter-Hicks classification. Do you think that this is an extraarticular or intraarticular fracture?
It's intraarticular fracture.
Intraarticular fracture, right? So do you think it's a type 3 intraarticular or do you think it's a type 4? It doesn't actually matter. You can have a small metaphyseal fragment which would make it a type 4. It doesn't make much of a difference to treatment. But the intraarticular fragment, so the reason I said that we need a CT scan is to look at the configuration. Here we did not get a CT scan, okay? But you think that there's a coronal plane split, right? So how would you fix it? Do you think this is good enough fixation that we have crossed the fracture line?
I think, sir, we should also put a horizontal screw, and along with that, we should put like a transverse K wire or something.
So you could put, if you think that the entire physis is disrupted, then you can put K wires just like I showed in the first case.
Yes.
So here we thought that this was an intraarticular type 3 fracture. If it's a type 3 fracture, you don't need to go above the physis, right? Because it's a type 3, it's intraarticular below the physis. So this is what the correction was. And when the clinician came back in the clinic 6 weeks post-op, you can see that now you can see that the entire physis is disrupted, so it's not actually a type 3. Okay? Some of the fractures cannot be classified by Salter-Harris classification. This had an intraarticular fracture, but the entire physis was disrupted. So the reduction was not perfect, right? It's inadequate reduction. And if you look at the CT scan, so we got our CT scan, and what you see is there's a alpha fracture, right? There's a split in the sagittal plane as well, besides the coronal plane. So we actually missed that alpha. Otherwise, the screw should be going from an A to B, right? If it's a alpha fragment, here we were going from medial to lateral, so we missed the fracture entirely. The good thing is that the patient did not have a growth arrest. This one did go on to remodel, so we didn't have any issues. But this just brings the point that you should do a CT scan before you treat these fractures. Anytime you see an intraarticular fracture of the distal femur. So if you look at this report, it's a frequently misdiagnosis in adolescent athletes, and they looked at 49 patients. Majority were type 3, Salter 3 involving the medial femoral condyle. 39% had misdiagnosis, so such a high rate of missing the diagnosis because you may not see it on the X-rays. And the displacement on CT scan was twice compared to the displacement on the X-ray. So you can't make decisions on the X-ray alone. You probably need a CT scan for all these patients with intraarticular fractures from the distal femur, and all of them require surgery. So let's look at another type of fracture, which is a patellar sleeve fracture. And this is equivalent to a patellar fracture in adults, but in kids, what happens because the physis is still there, or the apophysis, and it's a weak link between the skeleton and the ligament, so it pulls off a sleeve of bone and cartilage. And you can miss this. Initially I showed you the malpractice claims, but because of some missed fractures. And this is one of the fractures that gets missed as well. And what you see is that there is the patellar height is significantly increased, so that kind of gives you an idea, and you can get an X-ray of the other side to look at the patellar height, what is the normal height for the patient, and you can see that this is an X-ray of the other side. Because even if you don't see the fracture, when the patella is highlighted, once you examine the patient, you would know because their extensor mechanism is disrupted. You have swelling, you can feel the defects, you know that there is something going on. But if you just look at the X-ray, like a lot of our physicians just look at the X-ray or the report, you may miss it. So it's important to see these patients. And that can be an issue of palpable defect. And the thing is that the X-ray may miss it, and sometimes the MRI can be helpful, especially if you're in doubt about what kind of fracture it is, then an MRI will definitely help. If you look at this MRI, you can see that it's a pretty big piece that is pulled off from the patella. And the diagram shows what happens. You can get a very big articular surface along with the fracture. And so you have to open this area. Sometimes you can, even the patella, you can fix the articular surface with some, non-absorbable 4 or 5 conical sutures. You can glue it sometimes, and the way to treat this fracture is different ways, but basically you can do a patella tendon repair. So you compare pectoral sutures in the tendon, put your holes in the patella, you can pull it up, and that's typically the way it's repaired. If you have a big chunk, you can do a screw, you can do tension bend, but a lot of times you don't have much bone to work with, so you can treat it as if it's a patella tendon repair, and then there's this periosteum on the dorsal side. So here, this is treated with patella tendon repair with transpatellar tunnels, and then you can also subclass it, to protect the repair if you need to. And sorry, I'm just here. So this was done with attention and why. So that's another way of treating it. I usually would recommend using the patella tendon repair technique. Here is one of the biggest diseases that was published a couple of years ago, which is the transverse osseous repair of the sleeve fracture. 20 patients and 7 patients had no osseous fragments. So you can certainly miss this because there is no bone involved. And all had transosseous repair in the crack suture mixed in resulting on patients. All right. So the next one is an intraarticular fracture case. The typical mechanism for the tibial spine fracture is hyperextension and rotation of valgus. As you can see here, It's very difficult to miss this fracture unless, again, you can get small break fractures of the tibial spine where you don't have too much bone, it's just cartilage, and it's equivalent to an adult ACL tear, age 18 to 14 years. And the ACL stretches before the fracture. So if you get an MRI, there's always going to be some form of, edema, or they can say partial tear, and that's very common. It usually heals fine. You don't need to address the ACL. There may be a little bit of laxity after you fix a tibial spine fracture, but there is no gross instability in most of the cases. And you can miss it if the fragment is small and if you're not used to seeing this. And MRIs, especially if you're considering on-off treatment for this fracture, an MRI is important to make sure it's it's not significantly off. There's no meniscus entrapment. If you're going to be doing the treatment, retreated arthroscopically, you can treat it open as well. But if you're going to scope it, then you're going to scope the entire knee. So it's unlikely you're going to miss that meniscal tear. It's okay not to get an MRI for patients going for arthroscopic fixation. It's classified based on this Myers and Mercury classification. Type 1, you can treat with a long leg cast, and type 3, you have to fix it with screws or sutures. And the type 2 can be treated either way, though my preference is to fix all displaced fractures with a screw, so whether it's type 2 or 3. I usually don't attempt a course correction. I haven't had good luck with that. So I would use suture fixation if it's a little bit comminuted or if the fragment is really small. That is when I use suture fixation. When my exam fixation is a screw. Now, what complications you can have if you miss a diagnosis? You can get marks, lead to impingement, and for the laxity of the ACL. Arthroplasty has been reported in a lot of patients, and the key is early mobilization. That's why I don't like the calf, because you put the calf, it heals, but then also leads to a lot of stiffness. So I usually like to fix it so I can mobilize them. And then instability in less than 10% of the patients. If I put a transficer screw, which is most of the time, that's what I use, then I do remove the screw in three months, so the patient doesn't require second surgery. About osteochondral fracture, most of them are because of a patellar dislocation, either from the medial patella or lateral femoral condyle. The piece appears to be smaller on the X-ray, but usually it has a big chunk of cartilage attached to it. And if it's 15 millimeters, which is what our threshold is, it's not like an absolute threshold. If you think that the piece is a good healthy piece, then you should put it back. And when we have patellar dislocation and fracture, then we fix the fracture and we stabilize the patella at the same time with an MPFL reconstruction. And this is the case showing fixation of the fracture with tender screws and MPFL reconstruction, which is transficer. How about the tibial tubercle fracture? So these fractures are usually seen in athletes who come from a jumping injury, and we see a lot in basketball players who come down from a jump. And the common age is 12 to 16 years. Some reports of pre-existing osteoskeletal disease. CT scan is usually recommended if it's intra-articular and you're concerned about whether you need to open the joint or whether you can just hinge it down or close the door. A lot of times we would not open the joint or put a scope in, we just do open reduction of the fracture, and without looking into the joint, you can check on the fluoro. If you're happy, then most of the time it's well induced, but if there any doubts, you should just extend the incision, do a mini arthrotomy, look at the part of the fracture. So these are different types of intra-articular fractures. The one which is intra-articular and one which has a posterior extension are the ones which need surgical fixation for sure, but besides that, we need to be concerned about vascular injuries if there are posterior extensions. They may be displaced at the time of injury and then they reduce because of recoil and you might not recognize it. And so you can get compartment syndrome, vascular injuries. You've got to be careful. These anatomic reduction usually used and fixed with screws, like you can see here. But you need to be aware of the displaced fractures because you can see how the artery is tethered to the metaphyseal spike. So you can get some injuries, and you should do ADIs on this patient, which is the ankle brachial index, to make sure that they're not having any perfusion issues. This is the fixation of type 4 fracture with 2 screws, as seen here. Should be a case of a 15-year-old right tibial tuberosity fracture has failed 2 surgeries. Now, why would a fracture surgery fail? You look at this X-ray. So, any idea why did this fail? The patient had 2 surgeries at outside institution. Why do you think this failed? From the back, residents. What do your residents are? Ones next to you. Why do you think this failed? Next to you. Why do you think this failed? Anyone? Any residents or fellows?
Immobilization was not sufficient, sir.
He was immobilized for 4 weeks.
Okay.
But you're kind of right because he was allowed to go back to sports after that.
And the fixation was not very sturdy.
So you think the screw size is smaller, or number of screws are less, or what do you think?
I think screw.
Eccentric pull of the guys, these patients, and not allow them to go back to jumping for at least 3 months. And so this patient had been revised and we put in bigger screws, 4.5. We put them in a cast because he had, 2 times he had to go back to the, or he did fine. These screws don't have to be bicortical. They can be, this is cancellous bone, you can put unicortical screws, that's okay. But they need to be bigger screws. We frequently use 6-5 screws. And, in the diaphysis side, you can use 4-5, but on the metaphysis side, or the epiphysis, I would use 6-5. So if you look at the outcomes and edge you can use, or you can countersink them, because there's almost a 50% rate of taking it out. Let's look at my last case here from a metaphyseal fracture of the femur. And this was the fixation. So is this good enough fixation? Residents? What's wrong with the fixation here? Bond reduction is one. What else? Inadequate fixation. Because the two pins probably are behaving as one because they're so close and parallel to each other. Anything else? What do you think about the medial pin?
It's a welding. It must be an adductor canal.
Yeah.
It's an adductor canal. Femoral artery should be there.
Yeah. So would you have done it? Would you have chosen to fix it like this?
No, never.
I just was done by an orthopedic surgeon, right? So this patient came with the pain from the medial side and an avascular limb. And then we did an arteriogram, you can see the pain going right to the vascular tree there. No distal circulation. The patient ended with an amputation. So from a fracture which could be treated in a cast, it's actually not even required that this. This could have been treated conservatively. It's a young patient, metaphyseal fracture. There is no need for adequate reduction. Okay? You can just let it remodel. You can put them in a cast and they're going to heal. So over-treatment, not only that, but complication from over-treatment and led to an amputation. So you got to be careful, especially in neurovascular anatomy. And I've got so many cases of injuries to the nerves or the vessels from K-wires. Okay, so be careful. K-wires, you may think it's such a small size that it would not matter, but it does matter. Yes. All right. So in summary, don't miss intra-articular fractures. These are sort of 3 fractures of the distal femur. Articular spine fractures, these are frequently missed. Don't miss a patellar C fracture. Always examine the patient. Don't just look at the X-ray. And CT and MRI for intra-articular injuries around the knee. And minimally displaced fractures can be treated in a cast. Displaced fractures need full fixation. And you need to follow the patient because these are going to have some growth arrests and growth disturbances. So you need to follow them for a couple of years or till maturity. Thank you.
Any questions for Chital Bhai? Prakash.
Which
Yes, sir.
so I'm going to talk about supracondylar fracture because that is what Kamlesh wanted me to talk. And it's been 20 years I'm talking about supracondylar fracture, and still there are questions. So whenever we have supracondylar fracture session, for 20-minute session, 2 hours are not enough because everyone has questions, and it's not that every time we have answers. So let's find some more questions, and you can see in this picture, and we do every year a meeting to promote education about fractures in children at Pune in July. So this year too we have IFIX at Pune, and IFIX Express has gone across India now to Sri Lanka and Bangladesh, and soon it's going to go to African countries also. So Kevin, once in life, I want to have IFIX incident. We'll do a pediatric fracture course there. So first, coming to a technique, it's a displaced supracondylar fracture. The radial pulse is well fed. I looked at the capillary circulation, which was good. But if you are doing this OK side, this is on the normal side, and you can see the child is able to do that. But on the fractured side, he is not able to extend the fingers, which means I have a pulse ping, but with a with a neurological involvement. And the decision is very clear that in these cases, you still have to go for close reduction and fixation. Kevin, I'm sure we will not explore the radial nerve here. So he's nodding, and he seconds my decision that it's not necessary to explore a nerve when you have isolated nerve involvement without a vasculature. So this is an option when you anesthetize the patient and then you're arranging in CR, is to use CR as a fracture tape, as your support. It's very convenient to do it and very quick, but the problem is if you need to do a lateral view and if you need to shift the CR, you need all the support, and then the problems come. We have a very low cost solution here in form of an arm board, which you can make from any carpenter. It's a 3-inch wide board, 6 feet long, and it's around meters to doing supracondylar fractures with an arm board technique, multi-purpose, and you may register for Orthopedics to get a free hip spinal table. But if you don't want to register, you can still make this and save money. So, Maureen, I hope you are listening to this, and excuse for that. Some more practical tips: you can, mark your elbow, and this helps the CM technician. Many times they don't know where to shoot, and this will reduce the number of exposures and will have better fertility rate among pediatric orthopedic surgeons. So this is something we should do. Marking the center of the elbow. The 50% of the surgery is about getting the right exposure and CR. So now we put the arm board to drape the patient. You keep this arm towel because it becomes very easy to pass the AP and lateral pins. Otherwise, it's very difficult to pass your pneumatic drill if that thing is not provided. Periosteum is intact, medial is a little more damaged. There is a medial combination, so I know that this can go into varus if it's not fixed properly. And I know that this is a high energy supracondylar fracture, unstable variety, which I need to fix there. So this is the second step. After giving traction, sustained traction, you correct the translation in AP view. So I have pushed this fragment laterally so that I get good alignment in AP view. So you may feel happy, but that's not all. Now you have to get alignment in a lateral view. So you hyperflex, keep your thumb on the auricular nerve and correct the posterior translation. And here I have pronated because it's the injury demands that. And now I check my AP. This is the AP Jones view. It's also known as sometimes loser's view because you neither see forearm or elbow, and there is always a confusion whether your alignment is proper or no. So you can take oblique views. So this is an external rotation view. I call it a max view because it shows you the medial column. So max is for medial column. You can see the medial alignment well. And then you take internal rotation view, 45 degrees, gentle internal rotation view because it shows the lateral column back. This is what a limb view. You realize that supracondylar fracture reduction is about columnar reduction, medial column and lateral column. And if they are aligned well, you will not have secondary deformities. The lateral view is a problem. The moment you take a lateral view like this, there is a rotation on the distal fragment. So the alignment gets lost. So you want to remain in AP, yet you want to be able to lateral view. So if you cannot move your arm, it is better to move the C arm. So you move the C arm, and now you notice that there is a posterior translation. And how do you correct that? So the way to correct is in lateral view, keep the C arm in lateral view and push from posterior side, and then correct your alignment. So once your reduction is done, proper reduction, then you should proceed with pinning. There are many configurations for pinning possible. This is my favorite configuration. I put two divergent pins laterally, and in some cases I will add a medial pin if there is medial combination or if the patient is old. This is the lateral column pin which I will pass at 45 degrees. The second lateral pin is at around 30 to 45 degrees, and it goes through four cortices. It actually goes through the lateral condyle and it goes through four cortices. There is 30-degree deviation between the two pins. So these are two lateral pins. In a lateral view, it's important to realize the lateral pin does not go along the humerus axis. If you pass along the humerus axis, you get very little of the distal humerus. It has to go from anterior to posterior if it's a transverse fracture. However, if you have oblique fracture, then sometimes you are forced to put these pins from posterior to anterior. So entry point for the lateral pin is almost on the articular surface of the humerus, and then you go little 2 to 3 millimeters anterior to the midline point, and then you direct on an 80 view, it will be around 45 angle to the humerus, and in lateral view, it is 15 degrees going posterior. So you pass your two pins, lateral pins, and then check again 80 lateral, internal oblique, and external oblique. So having done all this, now I feel that of course I have two lateral pins, but this is still medial kind of big combination. It's an oblique fracture. This is not adequately stabilizing this fracture. So in this fracture, I decided I should also put a medial pin. Now medial pin, there is a risk of injury to ulnar nerve because in flexion, the ulnar nerve goes anterior, and then it's at risk for being injured with the medial pin. So first thing you do is now it's stable, so you extend the elbow. You extend the elbow to 30-degree position. Secondly, always enter anterior because ulnar nerve is posterior to the medial epicondyle. And if you are in doubt anytime, if there is swelling, if you are insecure, if you are not sure, then make a small opening. And this opening is not to explore the ulnar nerve. It's a small opening to feel the medial epicondyle, to make sure there is nothing between your finger and the medial epicondyle, between the K-wire and the medial epicondyle, so you are sure that it is not going to the ulnar. It also helps sometimes to use this little sleeve so that as you are passing the drill or the K-wire to the drill, it does not catch on to the sheath of the ulnar nerve and causes it to get irritated or rotated. So this is how you will do a safe ulnar pin in extension from anterior to posterior. And as Dr. Edwin Crawford has often taught us, use different size K-wires so that in lateral view, you know which K-wire is bent. So this is my fixation, two lateral pins and a medial pin. Again, you check for the pulse. I give a dressing, cut a gauze piece and give a dressing because while removing the slab, these wires should not come out. So small little tricks here, which I am sharing with you. The slab should be given in 45 to 50 degree flexion, never in 90 degree flexion. I don't give a cast. I give a slab. If plaster is required, if it's convenient, then I will generally do it after 3 to 4 days. So you will see there is a lot of padding. These are the days when we still used to use plaster of Paris. This session is supported by SCT and use that plaster now, fiberglass plaster, but you can see that I made some more changes in my slab. After giving the slab, I open it anteriorly so that if there is some swelling, it can be accommodated. I also made sometimes a small opening near the radial, especially cases which are pink pulseless head, and if I want to follow it up with a Doppler, I make an opening on the radial pulse so that it's easy to get a Doppler for a radial pulse. So when do we remove the wires? After 4 weeks, you know that callus formation is there. And remove the wires only when you are sure that fracture is deep. You don't have to immobilize this patient for 6 to 8 weeks. So 3 to 4 weeks is where you will be able to remove the wires and mobilize them. So this is complete the technique of standard supracontus. That was technique, and then 3 jugards very quickly I will go through. One is using a hypodermic needle to guide your KY placement. Now this is something I discovered from a paper using a hypodermic needle can help you. So this is again a supracondylar fracture. And it's easy to get this direction as compared to KY on the drill because it's a heavy thing. Once you get your direction on AP and lateral from this hypodermic 18 number needle, now it becomes easy for me. Now I know that my entry point is perfect, but my direction has to be little anterior to posterior. On a lateral view, on AP view, I know that this direction is okay, but I need to just increase my angle a little bit. So my KY now will go in that direction, and now this will give rise to a good fixation without multiple attempts and multiple Siam shoots. So this is what I found. The number of image intensifier uses will reduce. Again, you will see some differences in the technique I am doing. I'm using 2 different sizes KYs. This was after I fixed after postpone meeting at Ahmedabad. I've learned that that helps as taught by Dr. Neil Crawford. So these are 2 different things we are doing, and just 2 wires here because we thought those were sufficient. And another jugad I'm going to show you about flexion type supracondylar injury. So this is you must recognize whenever the fragment is in flexion and not extended, this could be a flexion type injury. This child has sort of ecchymosis on the posterior aspect. That is one more clue which tells you that the damage is on the posterior aspect. This is not fall on the stretch hand but fall on the point of the elbow. And the problem is these children can have ulnar nerve injury, which should be looked for. And second issue is if you reduce this in flexion, this will displace. So you must reduce this in 30-degree flexion position. So I'm giving traction and my hypodermic needle, and then you can see this is on the arm board. On the arm board, the lateral view is very clear. Now you know that the distal fragment is going in flexion. So because the arm board humerus is strapped to this arm board, now you can posteriorly translate it using a force against that resistance and get it to reduce. And now you will pass one wire in this position using hypodermic needle as a guide. Pass the second wire. This is done laterally, and then confirm your reduction. I will pass 3 wires because in this injury, so the injury side on the medial side, I didn't want to pass any medial plates, and this went on to heal very well. And ulnar nerve also recovered in this patient after around 3 months. So that's the second tip. The third tip for the day is when you get difficult supracondylar which you cannot reduce. For example, this is a 10-year-old child, but also 10 days old injury, and then this came in this status, lot of swelling, and treated by a bone setter somewhere else, and there is so much of translation. Are you going to do an open reduction? Really not necessary. What we did is, inspired by one of the papers where Sheetal has described, we did something known as intrafocal reduction. But at this stage, instead of using KY, as in this paper, we use an artery forceps because there is a lot of overlap, and KY was not really working well. So you take the artery forceps, which is a curved instrument, you put in the fracture side, and then turn 180 degrees. So you get a hold of a proximal fragment and then translate. It looks all good on animation, but actually it will work on table, and I'm going to show you that. So this is goes. Anyway, so we reduced this with this artery forceps method and fixed with K-bias as usual. And we were able to get this reduction also in a 10-day old section. So I'll just see that we don't think that we get quickly the last slides. It's happening at the same time. So you're seeing two tricks in one case. Use of proximal wire for delocation and use of more artery forceps for translation. And then you fix it. And here the wire
You're flexing also.
flexing also. And so elbow is not in, my control is with an artery forceps. I'm not flexing. And then you can see here my wire has gone from posterior to anterior because it's an oblique fracture. If I put from anterior to posterior, I do not have a good bone. You may have to change your strategies. And finally, you have 3 wires here. You remove the proximal pin and treat the slab. So I think it's enough for today. One technique and 3 tricks for all of you to go home. Thank you very much.
Any questions? Sir, whenever there is a fracture supracondylar humerus,
Kevin's is next top. We'll ask him to load the top. Then you can ask.
so there is a supracondylar humerus fracture. Associated pulse is there, but there are nerve involvement. So do you prefer open reduction or directly go for a closed reduction?
So there are multiple situations. If pulse is present
Yes.
and hand is pained, but only nerve is involved, then most of the time you will not do anything.
Sir.
The second situation, the pulse is present, the hand is pained. Before surgery, the nerve was good. After surgery, you have pulse. Then those you must explore. So nerve is in the fracture. Okay? If there is no pulse, but hand is pained, and no nerve is involved, you don't have to do anything. You just have to do close it. If there is no pulse, the hand is pained, but if one of the nerve is involved, especially anterior nerve, then there are high chances that nerve and vessels both may be entrapped at fracture site. And in these cases, if the fracture reduction is mushy, or if there is anterior fracture gap, then you should be ready to expose. I think there are these 3-4 situations, and you will act according to situation.
And all the surgeries are performed under general anesthesia or block anesthesia or short GS.
So my anesthetist, we have a very good anesthetist who is master of blocks, MBA. We call him as MBA, master of block and anesthesia. So he wants to give block for everything, and he said for supracondylar I don't want. So he said I will give a short block. There is nothing like a short block. So you must avoid blocks for the supracondylar because you will not come to know about the compartment syndrome if the child has pain post-reduction. Sheetal, what we do? You all give blocks or
No, we don't do blocks. For trauma, we try to avoid blocks. For any trauma patients,
any trauma patient?
we need to avoid because you need to do neurovascular checks. One other situation, and there have been reports on this, is
Sheetal, talk to the mic because
no, we don't do blocks for any of the trauma patients just because it can mask a lot of important post-op findings, including nerve assessment, compartment syndrome, pain assessment. But what we were asking about the nerve, one of the things is high median nerve involvement with the supracondylar. It doesn't happen too often, usually maybe with a rupert fracture, or sometimes it can happen if you have a pulseless hand. It's important to diagnose it because if you have a high median nerve palsy, then you would lose sensation in the. So you can have a compartment syndrome without the patient, crying or feeling any pain. So you're going to miss a compartment syndrome. So it's called a silent compartment syndrome, and there have been reports on that. So you need to make sure that you do a really good neurovascular assessment. And that's one of the keys of supracondylar fracture is to document your neurovascular assessment before you take the patient to the OR. Even if the patient is crying, even if the patient is not cooperating, you try and document whatever you can and try and get a good exam if you can, because it's really important.
You have done a good reduction. You have done a good fixation on table, you are happy. But how many times you have felt in follow-up that reduction is lost with the 2 or 3 products? And then what you do?
So
Because you
if
take
your-
X-ray 4 weeks of.
So we take X-ray at 1 week, but if your on-table reduction is good, and if you have stressed the fraction in internal external rotation, and if that has not been moved, generally we will not lose reduction. So I've not seen it happen. Sometimes we get delayed cubital pulse. Your fixation is good, it's healed well, but after 6 months or 9 months or a year, you start seeing some pulse. And that is generally because of something known as avascular necrosis of truncated, where there is a facial affection because it's especially in a low component. But if you're fixed well, loss of reduction is not seen.
The other thing is that you do not need an anatomic reduction for supracondylar. Translation can be modeled, a little bit of angulation can be modeled. You need to make sure that the Bowman's angle on an AP view and the anterior humeral line on the lateral view. As long as those two are intact, you can accept a little bit of rotation with small spike on a lateral view, or even some translation, and things would be modeled. So it doesn't have to be anatomic, otherwise you end up opening a lot of these fractures because you think that you need a perfect reduction, which you don't.
Well, there is a significant displacement of the supracondylar fracture, and there is a being pulse left hand and median of injury. Do you do the open reduction or do you try the close reduction? And after the close reduction, if you feel there is a median now injury and pulse is not there, saturation is 99, and the movement is good, but there is a intra-interstitial involvement. What do you think? And after reduction, of the fixation?
Yeah. No, I would still treat, if it's a pulseless but a perfused head, I would still treat it without opening it. If it's an anterior interosseous nerve injury along with it, that doesn't change anything. The only thing is, if I don't get a reduction good enough and there is a gap in the reduction, then I would suspect something interposed, but if the reduction is there, like an anatomic reduction, then usually there is nothing that I'm going to be doing differently. Now the threshold changes a little bit if you have a pulseless hand, but you are not really sure about perfusion, like you cannot Doppler the vessels. So that's the next thing we do when we do the pulseless, if you have a pulseless hand or a perfused hand, we would reduce the fracture. But after reduction, putting your K-wires, you get the arm in a little bit of extension. Most of the times you should be able to at least Doppler the pulses, okay, even if it's a pulseless hand. And if I don't have any Dopplers, then
I have 2 cases where one, initially the fixation was done for being pulsed, median nerve palsy, and the Doppler suggested that the artery in between the fracture sites. Then exploration was done and removed the artery and fixation completely okay. Second, the same thing happened. There is a pink pulse left and median nerve palsy. And and then after fixation, and the Doppler suggested there is no artery inside the fracture. There is median nerve injury, and they don't conclude anything about the nerve and what is the status. And I asked the 2 vascular surgeons what we do, we should explore or not. And one says no, it will recover, no problem. And the second says no, we have to explore. And there is the median nerve palsy. There may be a median nerve in nerve. And
yes, I mean,
they decided to explore. There is artery in between the fracture site and the median nerve lying posteriorly.
yeah, I mean,
Remove
so median nerve injuries are not that common. Like high median nerve injuries are not that common. So whenever you have a brachial artery, that means a pulseless hand and a median nerve injury, then the suspicion for a vascular injury is even more. So, then I usually call him because he's the one who does our vascular assessment. So I have that's another thing is to have someone close, your friend, or you need to call someone, in the middle of the night, you need to have someone that you can depend on. So I would just with that, I think we'll move on. We have a lot of speakers. I'll introduce Kevin, who has joined us, several times, and I'm really grateful to him for, helping us with the mission trip here in Ahmedabad, as well as I'm really lucky to have him as a partner because he's a backup on call for all vascular injuries, and it's a good help. So on to you, Kevin.
The risk of not exploring and missing is huge. So it's very easy to explore. You make an incision, you spread twice, and it's all open. So it's easy to find. I'm going to talk about complex distal radius fractures because it's very common, right? Kids fall all the time. And we're seeing more and more complex injury patterns because of lots of different reasons. Risk in kids are complicated, right? There's a very complicated anatomy, but there's a good soft tissue envelope that helps in healing. So they almost all heal except that case we just finished. Why that didn't heal, we don't know. But in most cases, the ligaments are stronger than bone and cartilage, so you should watch out for occult injuries that pull off pieces of faces. Up to age 6, and then in playgrounds, and then older sports for us, football, or maybe cricket. I see a lot of cricket injuries in my practice. When I find patients, I want to get a little bit of the history. How they hurt themselves, what was the mechanism of injury. Any treatment, you see a fracture that looks good on x-ray, but maybe it was really crooked and it pulled on it, made it straight. So you're like, I've seen that happen a few times. And then the neurovascular status, make sure you look at that. And if you can't find the precise location of pain, if you're worried about a injury, where to hurt exactly, that helps you figure it out. And then the things I look for, looking at the arm inspection, palpation, finding points of tenderness, and range of motion, especially the fingers. If you're looking at distal radius fractures, how do the fingers work? Is there a sign of nerve injury or entrapment or something? And then get good radiographs. X-rays are really important to get a good AP. Sometimes a skateboard view. Advanced imaging for concerning fracture patterns, CT or an MRI can be helpful, especially if you don't see anything on an X-ray. An MRI might show ligaments or cartilage injury that you don't really see. For me, if I see a fracture on X-ray, I want to see if it's in the joint or what pieces are involved in a CT scan. So things that I don't worry about, these are some problematic cases just to talk about. The more time I have. So this kid fell off a general gym. Bilateral wrist pain, left was really bad, the right not so much. And so reduced expensive ED. This was the right wrist. It was called a buckle fracture by the radiologist. But if you take a closer look at the X-ray, it's really a soft Harris 2 fracture, or I say a buckle Harris 2 when I show it in the clinic. And so with that, you have to worry more about growth arrest. So most people were worried about this fracture. Salter Harris 2 also reduced, but this one not reduced on the X-rays. So for me, she's also becoming ultra positive, where she wasn't ultra positive before, very subtly. So we get an MRI, it showed a 35% fascial bar from a buckle fracture. And then TFCC therapy, that onset of wrist pain stimulation. Arthroscopic repair of TFCC, and then physiodesis of the sternum. So it's a complicated injury. It doesn't look so bad. Sometimes the ones are sneaky, right? The really bad fracture, that's the one everyone worries about defining the problems. So this is a 14-year-old who had a bad looking injury. These are the best X-rays you can get. So he's skeletally mature, immediately. We didn't want to do an opening of the ulna to cause more something. And then I went out of town the next day, and unfortunately developed compartment syndrome, and taking the OR on my partners. Being one of my partners that can help me out of town too. So we watched out. 6 months post-op, he came back to see me for another injury. He's doing great, no problems, full range of motion, still playing football. But the high energy injury, those ones that you worry about, doesn't you have to watch for the soft tissue stuff too. Third one, the interarticular fractures. This kid has a type 1 OI, very few fractures, and a mild deformity from the wrist. No numbness, tingling. It looks reasonably good. Was reduced in the ER and then casted for 4 weeks. But because it's a articular shearing fracture, it's not diagnosed as a bad injury until healing. And then you can see, get a CT scan, it's healed. Take the step off, no extension of the wrist, and then a lot of them. So at this point, she's healed, but healed in malunion because these shoulder shearing fractures. If you see the fracture playing like this, the carpus follows the volar fragment, and so the whole wrist joint will fall apart. OI, you need to do something. I hate to put a place in OI, but when you have a bad interarticular osteotomy, then you have to do that. Of course, she's hard removal early. A little bit of malunion, but not bad. And doing great 1 year out. Last kid with a traumatic wrist fracture, injury in football, we see this all the time. Fall, break their, hurt their wrists, keep playing the rest of the year. And then the next year rolls around when they're trying out for the sport, they have wrist pain, so they never see me. But mostly it didn't hurt too bad. So, and of course, mom is a radiology tech, so mom takes x-rays and never got an x-ray from him because we're medical providers. Do that for my case too. Brush it off. We got an MRI because you can see the scaphoid fracture on CT x-ray. And then it shows an avascular non-union of the proximal pole. But unfortunately, in our experience, in kids younger than 21, probably you don't have to vascularize the distal. It's younger than 21, probably you don't have to vascularize the distal ring other than the proximal scaphoid. It heals pretty well on its own. Just stabilization. The stabilization does not need vascular ring. Putting a screw across it can help bring blood supply into that small piece of bone, and then the single integrated screw or dorsal approach just to raise bone graft into defects. So there's 2 cases I think of things that I think about when I see 100 fractures in the hip disarrays. There might be 1 or 2 that you need to know that are going to be bad and worry about. These are the ones that shock. So from that, I welcome any questions, and I hope you find me back again.
Yes, question?
Yeah, great talk, Dr. Love. My biggest question is, like, what looks subtle on a Salter Harris tube buckle fracture? Michael? Do you counsel every single patient, like, that they're going to possibly have a growth arrest? My question is, do you counsel every single patient, like, they're gonna possibly have a growth arrest? Or is this something that you address only after it happens?
So I tell every patient with a Salter tube fracture the 1 to 3% chance of growth arrest, and I monitor everybody x-ray in 3 months and 6 months. And so we've got a bunch. I think it's better to take an x-ray and catch it early to do a distal microcedesis than wait until 2 years later. I just took care of a kid that one of my partners saw just raised Salter tube that was pinned. And after 6 weeks, said he'll fall, you'll be fine. It starts to hurt, come see us. So 2 years later, it became like 8 millimeters on the positive. So that's hard to fix. So I tell everyone, like, it's a low risk, but you want to catch it early if you can. So,
What do you see in 3 months that I should be looking out for? So in 6 months, I probably am going to see it. But what do you look for in 3 months?
so 3 months you can tell, and a lot of distal radius fractures that are growing, you can see the growth from the 1 month to 4 month healing. So you can see growth and you know they're growing. If all the variance stays the same and they're growing, then you can say they're doing great. But a lot of times I'll see them in 3 months and say, I'm not sure, come back, it's 3 more months. We'll take a look at it. And then usually by 6 months we know for sure. But I'm not sure if that's.
But if it's an undisplaced Salter fracture, 1 or 2, I usually don't see them back, but I explain them that you need to keep a watch on it. If you see deformity, if you see anything in future, then come back, because as you said, what am I going to do if I'm receiving them? Most likely it's not different than when they show up to see me. It may be a little bit late, I do agree, but the number of fractures that we see, means undisplaced Salter 1, sometimes even occult fractures that we don't know they're true Salter 1 unless you're in MRI. So those fractures are Salter 2 with very faint line. I don't see them back. I put them in a cast, and they come back to get a cast off with the technician. But I explain them. Now so probably 1% or less than that may get affected, but the Salter head is, or the 5-cell arrest has been reported even with a metaphyseal fracture. Okay, like Salter 5. So there is no way that you can even if you screen all these patients, there's no way that you're going to be able to prevent anything. And as far as treatment is concerned, I can treat them if they have a problem. Right? So I tell them that there is a small risk. Just keep an eye on it. If there is any issue, come back and we'll get X-rays done. So it's a little bit different approach, but as long as you tell the family,
I really want to go look at all of our thousands of cells not have growth arrests. But I think in my experience, the ones that are more displaced, like displacement is the biggest risk factor, and then age, close to our cell maturity. So kids under 10, I say I don't even think it's going to be something to worry about. But if you're 12 and over with a big, dorsal, high risk to me, 50-80%, I think. So overall numbers are low, but there's some high risk ones and big ones.
with that, I will introduce Manicure Chair. She is also not a first time in here. She has come here multiple times, and we thank her for all her efforts and helping us out with the mission trip. She's extremely well trained pediatric hand surgeon, and she works in Toronto. And welcome.
Thanks so much. I appreciate you having me here. Thanks for your invitation. Sorry, I want to apologize for my voice. So people cannot hear me. Just let me know when I'll see little pulse, little fractures, and their manifestations. I see a lot of post-traumatic deformity. And so there's this concept of cases here to highlight these lesions. So this is an 11-year-old guy. He's healthy. He had a fall playing basketball, and he sustained a right elbow injury. He had swelling and pain in the seat in the emergency room. And he was told, no fracture, go home. And so, take a look. Perfect. Our radiocapitellar line looks aligned. We see our routine growth plates at this stage, what we expect. We go back to our textbook and make sure every little thing that we see is present, not fractured. Perfect. It's pretty good on our matches with our APB here. And so this is all we need to need a test. This is the 100 from task on, feed it back in a week, and then take it off and get them going in the meeting. Well, that brings us to the concept of the trash lesion. So what is that? What does that mean? And so it's an acronym that was formed by the Boston group called the radiographic appearance seemed harmless. In general, that's to the pediatric elbow has a very benign innocuous appearance on X-ray. And these often involve osteochondral intra-articular lesions that really are not visible on plain films because of the immature skeletal age. And if they are missed, higher energy fall, and clinically their pain and swelling really do not match the radiographic appearance. So these kids with high energy, very swollen, take a further look at the X-ray. And so from that paper, the corner trash lesion, they have multiple injury patterns that fall under this category. But I really want to focus on the radial head because I've seen a lot of these and a lot of these are missed. And so I'm going to bring you to a case example that I saw in St. So the 6-year-old girl, she tripped over a ball, and that was in June. And she's seen at an outside hospital. said nothing wrong, treated and cast. And at the 1 week fracture follow-up at that hospital, the surgeon takes a look and says, go to sick kids. And so she comes to our sick kids fracture clinic 3 weeks, about 3 weeks following her injury. So take a look at her initial radiographs again. Everything looks okay, alignment's good, I don't see anything too terrible on here. But then her 3 week radiograph at sick kids starts to show this here. And so we got an MRI, and again we can see now there's a large intra-articular radial head fracture. It's displaced. There's a gap. There's some subluxation. There's junk in the joint. And so we took her to the operating room, and you can see she had a very large, almost half the radial head with some combination here. And so we had to fix that, but that's, at least on X-ray, very, very benign appearance, but again, a highly swollen elbow. And she's just lucky that something appeared on her X-rays at 3 weeks. Okay, so that just makes this couple of 1.3 screws. So that brings us to the intra-articular radial head fracture. And so this is a study that was done of just looking at intra-articular and extra-articular radial head and neck fractures. And this is pretty rare, only 4% in that retrospective study were intra-articular radial head fractures. The average age was about 8 years old. And so at initial evaluation, look at how low the numbers are. So these are missed fractures. And up to 25% of these intra-articular fractures were missed at initial visit. So if we come back to our first case, the case that introduced our young boy with the elbow injury, he now comes back, but 3 years later. He's 14 years old, he's got elbow pain, he's got swelling, stiffness, he's got decreased flexion extension arc, decreased supination pronation. He has no instability frankly. And then these are his x-rays. So now, sorry, I don't have a great lateral view, but now what we see is this very misshapen radial head, malunion, non-union, with a gap, and some arthritis on the forming. So what if we take a look at the original films and take a look really, really closely? We blow this up, just with spinning and postural migration. So still, it doesn't seem like it would be the best option. So we look back here, and this kid has arthritis. So this is a case that, as a fellow with Kevin, Cincinnati Children's, and we went into the joint to look at it, and it was completely destroyed. So we opted to do a regular head resection. And so that brings us to a study that Kevin was leading as part of, and it's a multi-center retrospective study. So looking at comparing treating radial head fractures early versus a salvage excision. So the early primary surgical treatment of intra-articular pediatric radial head fractures improves outcomes and decreases need for salvage surgery. So we hypothesize that you diagnose these early, treat them with or for whatever they need, it lowers the risk of progressive joint arthrosis, subluxation, decreases the need for subsequent salvage surgery. So a multi-center retrospective drug review, all patients were pediatric, they all had isolated traumatic intra-articular radial fracture. We broke them up into 2 treatment groups, one that were identified early under 30 days, and a patient that were identified later than 30 days. And our primary outcome was successful union, secondary outcome was a need for salvage surgery, a radial head excision. So there was no difference in demographic data. We had 36 radial head fractures, 35 patients. We looked at the initial fracture pattern, no difference in the fracture displacement or percent radial head involvement. But when we looked at the patients who were initially treated non-operatively, there were 12. There was only 50% of these patients that actually went on to a successful union. And notably, all of those 50% had under 1.5 millimeters of initial radial head displacement. The other 50% went on to salvage surgery, developing radiocapitellar joint arthrosis requiring a middle head excision. And those who were identified later had significantly increased risk to having a salvage surgery. Okay, so 67% versus 17%. We looked at the people who were treated operatively initially, so 24 patients treated with ORIF. 88% went on to successful reunions, that's compared to 50% with the non-operative reunion. 12% though still had to go on to salvage surgery, 2 for radiocapitellar joint arthrosis, 1 for avascular necrosis. There's no difference between the early and late identification groups. So conclusion with regards to intraarticular radial head fracture management from this study, we recommend early ORIF with an 88% median rate. Non-operative treatment can be considered if displacement is under 1.5 millimeters, and early identification results in less risk of salvage surgery. I have a couple more slides, but I can stop there. Yeah, okay. Our last study is just looking at our results following radial head excision. And so this is the experience in Cincinnati. Retrospective chart review of Dr. Little's and Dr. Cornwell's patients identified 13 patients who underwent radial head excision for a trash lesion. They all had severe radiocapitellar joint arthrosis. Average age at time of injury is 11 years old. Mean age at the time of surgery 13 years old. But the average delay to referral or surgery is about 2 years. And this paper is followed about 9 months, so short term. What we found though, immediately, significantly increased flexion extension and supination, pronation, approaching significance. Reported outcomes were pain relief, no instability, the MAP score was 55. One person reported wrist pain, one person had a radial head overgrowth, so kind of similar to that previous paper I presented. But all 9 of the patients who came back for follow-up had wrist x-rays, had all their positivity that developed, and that average was 4.6 millimeters. So this proximal radial migration is a real thing, and is definitely food for thought when you're excising a radial head. This paper, this study needs to be updated because Kevin recently saw this kid 5 years out. He's asymptomatic, and now he's got 10.9 millimeters of all positivity following radial head excision. All right, so in general, familiarize yourself with normal patterns of secondary ossification centers. Time and flap on the bone on X-ray does not always equate to a tiny injury. Minor joint malalignment is not a minor issue. Mass facility and practice with normal radiographs, considering MRI. Right? So, in conclusion, radial head excision may be good for short term. We don't know the long term. You need to tell your patients that they could develop some positive variants. And we know nothing about arthroplasty population, so could be some extent. Early recognition.
So, great talk. But the question is that, we know about the 2 studies you have done. We know that intra-articular fractures, if they are displaced, they have gap, they need to be treated. And if they are not treated on, diagnosed date, they have problems. But the main issue is for the trash lesion. Like, how do you diagnose a trash lesion, like the X-ray that you showed, when you can't see it on X-ray right now? Like, do you do an MRI up front when you see it, suspecting that there is a radial head? What are you going to do if it's, small fragment and the subluxation is progressive with time? Like at time 0, if it's not sublux and you have the undisplaced fracture. And the reason I'm asking is, we shared a common patient who had bilateral and intra-articular fractures. The site that we treated ended up with all the issues. Like, she ended up, if we fixed it, she ended up with, arthritis. We ended up with excision. The other side, which was untreated, she's doing fine on that side. And so that leads you to think that there may be a lot of patients with trash lesions that may have done well, but we don't know because they never come back, we never know the denominator. And we're only seeing the ones that are, getting all these issues like progressive subluxation. So my question is like, how do you identify it early, and how do you know whether this is going to fall or not? Like, do you treat all of them even if they are on this place you recommend surgery?
I mean, you bring up a really good point about knowing the denominator of this population. I think honestly, probably the history of clinical exam are the biggest factors in being able to discern whether or not you should push for obtaining an MRI at the time of injury. So those patients of high energy who may have tiny little plaques and they have massive swelling. Or a history of dislocation and was popped back in, then those would be the kind of patients that I'm more adamant getting an MRI. But you're right, going into looking at the pediatric joint, elbow joint, and fixing it, that also is not enough. And so I think from our studies saying that even if you identify them, but the displacement is under 1.5 millimeters, I think it's safe to watch that, but watch it carefully.
I was going to say, I think the data is suggestive of the fact that you can treat a fracture that's less than 1 millimeter in place, but you have to watch. If it progresses with any kind of subluxation, that's what the problem is. It's not the fracture, it's the subluxation that happens. So if they're lined up and they have good motion and they're not subluxating posteriorly, you always see it posteriorly falling out. The cup shape of the proximal brace slips out of place and the joint starts to.
But what I'm saying is at that stage, is it too late and it's already a salvage surgery when it starts?
No, our data would say that if you fix it within 6 months, most of the time they do well. So you fix it late. I had a patient that lady sent me one of ours. It was like 4 or 5 weeks out, I went back and fixed it. And then it was healed. But basically, we gotta be confident. We didn't fix it until like after 6 months. It was already subluxating. So that's the, pain, subluxation, loss of motion, those are all good factors. So if you see that, then fix it. If you're not, then I think you're right. There probably are a lot of radial head fractures that are diagnosed as radial head fractures, but they heal. That's the reason how big the cartilage is. If it's 10% of the radial head, it's probably going to be fine. If it's 50%, it's probably something. You can't tell that on X-ray or on the MRI. That's the. Who gets an MRI? That's
Then what is the scene in India like? What do you see this often? And
So we are seeing this after getting exposed to the paper and after giving talks at IFIX. The mind does not, your eyes do not see what mind does. So I'm sure with each one in the audience here, and people who are watching this talk on Auto TV, once they now, if they see now, they will recognize, investigate everything. That's why it's important to know. But if I have to say in one line, if there are any child who has a painful elbow, with X-ray looking normal should be investigated. Because getting an MRI which is normal is not a problem. But if you miss a vision like this, very well summarize that a small break is not a small injury. My question is, I've had done radial head excision after compulsion in children, who are 10 years plus, and you have to do it because those are productive years and they need promotion supination, and there is a risk of ulnar variance. In one of the child where he had a wrist pain because of ulnar variance, and he still had growth left, and I did epiphysiodesis of lower ulnar to compensate for loss of growth from upper end radius. So is that a good strategy? And secondly, children who have symptomatic ulnar positive variants in mature children and immature children, how do you treat them?
So for immature children, it depends on how old they are, but I'll do an ultrasound and ulnar shortening osteotomy. I'm never shorting more than 5 millimeters. I think that changes the tension in the intraosseous membrane. I will consider doing fascial ablations if they, if they're over kind of 11 or 12 years old. And then consider putting a scope in as well. If they are having persistent donor side abuse pain, I'll often see a cartilage flap of the TFCC central tear that I can divide, or even a combined. I've seen a lot of combination tears where they have a peripheral and a central tear, and it's flapping up and impinging. And so doing a TFCC repair at the same time. Yep, I've had some really great results to the arthroscopic assistant. For the mature child, just like I treat my adults. So I just do all the shit in osteotomy. If it's more than 5 millimeters, I will consider doing an osteotomy in both. But I try not to for those those concerns about compartment syndrome and genetic problem.
To answer your question, in all of our patients that we had a few with wrist pain, and most of the time the therapy really got better and just strengthened. Even though the wrist was way out of place, I don't want to go chasing my tail and show them that have more migration. So, fellowship made a couple of adjustments, ligament reconstructions with the bone tones and the bone on our graft. This is surgery, and I think that would be the best solution for the child. I think that, in general, just wait. It's not too bad. Thank you again. Wonderful to have you. Our next speaker, Story Delaney, occupational therapist at the Cincinnati Jones. We'll talk a little bit about the therapy aspects of treating fractures.
All of the previous talks have led to hopefully all of those kids have had occupational therapy or hand therapy. This is just basically discussing when to phone a friend after a trauma, which meeting a hand therapist or occupational therapist. Indications for early referral to hand therapy, any specialized orthotic needs, complex trauma, allergic dynia or hypersensitivity, sensory re-ed, and persistent pain or range of motion patients after a 2-week range of motion check. Some specialized orthoses that occupational therapists specialize in, for nerve injury, tiny hands, any that need to facilitate motion, removable cast for protection when returning to sports. These are some of our examples. Following nerve injury, we use an anti-fall splint for an ulnar nerve injury, thumb spike or short component splint for median nerve injury, and then a MPA extension splint for a radial nerve glove for a radial nerve injury. Some examples of splints for facilitating motion, serial static orthosis, like the elbow extension splint or the elbow flexion splint there. Serial casting, we do serial casting on elbow, wrist, fingers, static progressive orthosis on lots of joints. And then a relative motion orthosis for facilitating finger flexion or extension. We also had a big push for a kind of like a rigid splint for return to sport. Kids with distal fractures who are anxious to get back on the soccer field, we can fabricate that and it provides protection so they can still play. Other complex trauma recommendations for hand therapy, wound and scar care can begin during the immobilization period. We also help with edema control. We also provide adaptations to get them using their injured extremity. The more they use it, the more they are able to cope. Coping is another big piece, depending on how traumatic the injury was. And then setting the expectations for recovery, what to plan for, what to expect down the road. This is just a little quick example of a gunshot wound to the left index finger. It included a P1 fracture, a flexor tendon injury, extensor tendon injury, digital nerve and artery repairs. Data surgery was in June. The pins were removed in July, but the referral therapy didn't happen until August. This created lots of problems. If a referral therapy happened when pins were removed, a lot of things could be prevented. At her first therapy visit, we fabricated a hand-based splint for protection. She wouldn't look at her hand, she wouldn't touch it. She had very thick scarring, and then she would do active range of motion for the unaffected digits. Second therapy visit, she had not been taking the orthosis off. She was very scared. She had allodynia, no range of motion, no wounded or scar care, so that scar was getting bigger and bigger. And then she also discussed having a lot of kind of PTSD of the incident, and that's part of cast is off as if they're very tentative. The parents are super anxious, the kids super anxious. That might be a good reason to send a referral. So then they might just guard it and not use it. Any hypersensitivity after a cast is removed too. I know it's hard to tell because many kids just have that. But yeah, I don't know that there are any other specific high risk cases that would indicate more.
All right, thank you. Who's our next speaker? George. Jordan is going to talk on cleft. Left hip.
પ્રસાદ વગર ભગવાનના દર્શન કરાવો.
I'm Jordan Darn, and I'm one of the fellows at the University of Cincinnati this year. So I'll be talking about pediatric knee fractures and dislocations, which is a very broad topic. So I'm trying to condense it down to the most important things that many of the generalists should know about and watch out for, and maybe if they see these things, should think about sending to a hand injury. So knee injury is very common in kids because they're always running around using their hands for everything. And it's no surprise that most of them are employees because they're usually doing more of the dusting. But there's a bilateral distribution. Positives tend to have more distal valence injuries just because of getting them slammed indoors and things of that nature. But adolescents tend to get them from sports, doing more fine motor skills with hands and stuff like that, causes phalanx and metacarpal injuries from the sports that they're playing. The proximal phalanx is most common, and of course the border digits are often most common because they have potential to be angulated and kind of hold on. So metacarpal fractures, they're usually at the neck or diaxial. That's a compressive or torsional injury. A lot of kids will see punching things, or any kind of phalangeal fracture, which is usually like a proximal metastasis, or it could be a biseal injury as well. So that's 20 to 30% of hand fractures in kids are biseal, but we rarely see a growth arrest. So if they're treated properly, then you don't have to worry about that too often. And the majority of pediatric hand fractures locally can be treated non-operatively. So the problematic hand
fractures are the ones we're going to go through, which cannot be treated non-operatively. So there's multiple studies that have identified those high-risk pediatric hand fractures. They include a displaced intra-articular fractures, skin fractures, phalangeal neck fractures, and of course open fractures. So risk factors of the problematic ones is a failure really to assess what needs to be done. So a failure to see this rotational deformity or angular deformity and kind of address that before it's too late. And a lot of times it can be a failure to obtain good imaging. You want to make sure you're getting specialized imaging of the digit itself. Don't settle for anything less than a good lateral and AP, and make sure that you can sleep at night knowing that it's not displaced. So we'll start with metacarpal fractures. So the small finger is the most common, and that's usually because it gets caught on something, or sorry, not caught on something, it's usually punching, and that's obviously you're leading up when you're punching. So to assess a line rotation, into deflection can be kind of difficult, especially if they're fresh off of an injury and they're swollen and they're not going to want to move it for you. So passive tenodesis can be really a great tool to have. So you just kind of passively extend the wrist, flex the wrist, and you want all of your fingers pointing towards the volar fold of the scaphoid. You don't use your other hand. Dr. Crawford said, got to get to the orthopedic surgeon that you have two limbs. So assess your rotation on both limbs, and if you do anything out of the ordinary, then kind of be hyper alert. So metacarpal back fractures, they affect the rate pretty evenly. Most commonly, you can treat these non-operatively, but if you do have a pattern that's unstable, so you have a long week, or we're going to talk about some a little bit later, then you might consider attending just to maintain the stability, let it heal without a rotational deformity. So 50 to 60% of metacarpal base fractures occur in the small finger, and that's like what we talk about because of people punching things. So you really need to be concerned that these are not just a fracture of metacarpal base, but there's also a dislocation, which is often missed on plain film x-rays. So you want to be sure that you're getting a good lateral so that you're letting the child leave with a dislocated C joint. And sometimes like a 20-degree pronated view is a little bit helpful too, just to see the metacarpals better so there's not as much overlap. Most of those can be treated closed if they're stable. So if you're able to make sure there's not a dislocation, treat them closed in the cast. So phalangeal fractures, the majority of these are proximal middle phalanx fractures that can be treated just buddy taping and splinting. Often the diaxial fractures are in adolescence and related to sports. It's really important to evaluate for the rotational deformity, like we said. Some of these can be due to like tugging on the derivatives and things where the finger gets really angulated. And that's pretty obvious to see, but sometimes it can be subtle. So examine contralateral hand, kind of like we already talked about. Buccal fractures also can be subtle on radiographs. So you want to correlate with your physical exam. If a kid is point tender right over a bony spot, even if you don't see anything on x-ray, lead on the air of caution, maybe just treat them close, have them close follow-up, treat them in a splint with close follow-up, and then you can always see if there's some remodeling on x-ray and then treat further into that, or if they're totally non-tender, then you can let them be on the rear. So Salter here is 2 fractures are the most common. The NP kind of allows for more motion than the PAP does, so you just want to be aware of that. You can't really accept as much for the PAP. And then you want to reduce the NP joint flexion to tension the collateral so that they're not getting super stiff and intrinsic loss position. That's kind of how you want to treat them. These are called extractive fractures, so Salter 2 fractures at the base of the small finger, which is kind of what I was talking about when they're pointing off in space. Some people will reduce these with like a pen. I've always been told not to do that because you can cause some crush injury and nerve irritation in that area, but you can reduce these oftentimes in clinic with a block and then cast them.
So the phalangeal neck fractures really need to be concerned about as often a finger that gets closed in a door. You can have these that displace into extension, rotation. They can be difficult to assess because they're small. And like all kids' fingers, it can be difficult to see on X-rays sometimes. So you need to get a true lateral because if these have any sort of displacement, they have a high rate of avascular necrosis due to the blood supply with phalangeal neck being pretty tenuous. So if they're displaced, these need to be pinned. There's a whole classification which I will not go into, but that's kind of just stating what I just said, that you need to be concerned for avascular necrosis, especially in displaced neck fractures. So the intercondylar phalangeal fractures is kind of like the lateral condyle fracture of the finger. It's pretty obvious that this is, if it does heal, it's going to heal in a very angulated position. So you need to be on high alert for these, and most of them will require attending so that you can stabilize, reduce the joint, and they don't get angular deformity or some sort of arthritis contracture later on. And it's often helpful to kind of put a template around that little teeth so that you can pull it up and then shoot your K-wire across after it's reduced. Distal phalanx fractures occur all the time. I'm sure you see these all the time. Little kids that get their hands caught in all the doors, and we don't really think much of it, but you need to be careful. So we'll talk about femur fractures in a second. You can also get pretty substantial suboptimal hematomas with these that may or may not need high penetration or removal of the nail plate. But usually you can just blunt these and then allow for some soft tissue rest and see the kid back and make sure they're healing appropriately. A lot of these will have nail bed injuries that do require you to remove the nail bed so that you can repair the nail bed injury and prevent nail deformity later on. But that can be done in under a block, with just some chromic suture that dissolves. They don't have to come back and get it removed. You just kind of counsel them on you may have some nail bed deformity later. But the femur fracture is a bit of a different ball game. So this is where you have a displaced here's one or two of the distal phalanx, and a lot of times you have a nail bed emulsion from the epicondyal or epimychial fold that gets caught in your fracture site. So it occurs because you have the FB that inserts on the metaphysis and then makes sense around the epiphysis, and you get this deformity that kind of allows for the nail bed to just get trapped within there. So you should treat it. Here's a white case count X-ray. It's going to be very white, but I think the more evident picture is when you get clinically like this, where you can just tell, something's not right with that nail plate, and they often have a wound right over that area. So these need to be treated as an open fracture with an IND, nail plate removal, and then repairing the nail bed, making sure you're getting that out of the fracture site. Some of them need to be penned, but a lot of times they're stable. Just send them on antibiotics and closely follow them up so that they don't get infected, or if they do, you catch it early. MCP dislocations, these aren't as common, but most of the time they're simple dislocations that you can reduce casts and you'll be okay. But you just have to be prepared to not pull straight line traction because these can get tethered between some structures, which doesn't allow for them to reduce. You can actually cause that complex dislocation by pulling traction on the finger. This is just a picture of those structures. I'm not going to go into the anatomy of it really, but just be aware of that so that how you want to reduce these is you want to flex your wrists, flex your MPs, and then you push them back over if it's dorsal, or you can apply some pressure if they're roller. Under a block, of course. So IP dislocations, dorsal dislocation is the most common, so you'll often have a volar plate injury, which can get interposed. These kind of have the same thing where you don't want to reduce them by pulling traction because you can pull that volar plate into your joint and then you're not going to be able to reduce it. And with that being said, you're telling one of the ER doctors or someone to reduce this finger and it's not going in, then you should be on alert that there's something in the joint that's probably going to need to be open to allow you to reduce the fracture. Volar dislocations are less common.
but you want to be concerned about central slip injury with those, which needs a little bit different treatment. So in summary, the majority of hand fractures are treated non-operatively, but I try to kind of focus on those that do need operative fixation, those that should be seen by a hand surgeon, and those that you should be following really closely. Just carefully assess the patient, clinical exam is key, and then good radiographs. So these are kind of the four you should be on high alert for. Thanks.
Question?
So for the femur fractures, do they always need a pin whenever you wash them out? Or what is the indication to pin them?
Yeah, in my experience, they don't. Only in my experience is not like as long as I know. But if there's stable injuries, you can stress them in the OR, then I don't.
Dr. Little has a big experience.
A little bit of the experience. Yes. Yeah, I agree with Jordan. We generally will like clean it out and repair the nail bed, and if repairing the nail bed, the root keeps it stable, then it's fine without a pin. If it's missed and infected and really gross, then we usually will wash it out and come back a few days later and pin it at that point just to give it some stability. But for the most part, in a acute trauma situation, we just repair it and almost never use the pin.
Thank you. Yeah.
Hey, great talk. Thank you very much for this. I have a question. Since many of these fractures are treated non-operatively, I have a question for the non-operative treatment. When we put on an intrinsic plastic cast for a metacarpal fracture, oftentimes we don't really get 90 degrees on the MCP joint, but rather a more extended position of the MCP joint. In light of having the MCP joint 90 degrees the most stable, my question is, in what extent should we insist on having the perfect intrinsic about 90 degrees joint? And the follow-up for this would be, what are your tips and tricks for having the perfect cast in this position?
Okay. My tip is I actually like to kind of give their wrist a little bit of extension because, like we talked about the tinnitus effect, they naturally flex at the MP when you do that. So if you actually just hold the kid with a little bit of wrist extension, I find that they kind of fall into place. And I don't think I was ever able to get them to 90. I always thought that that was what you should do as well, but I don't routinely get them at 90 and they still do fine. So I'm not
Again, for 99% of hand fractures, you don't need to worry about it. For really complicated polytrauma, lots of swelling, people aren't going to move for a while, bad infections, then you should worry about it. So if people are immobilized for less than 3 weeks, not going to be an issue. But if you're immobilized for a long time or something else, like if you have a crushed hand injury with multiple dislocations, then yeah, maybe you can think about it. If you really want to do it, you got to pin the fingers in flexion. That's the only way to hold that perfect.
Yeah.
Right down into the
I think it's more relevant in adults too because they tend to get more stiff, but kids really don't. So even if you don't have them quite unflexed, they still do.
For the sake of time, we're going to stop the academic program here. So we still have really great speakers. Maybe next time we'll have them give their talk. I think we would do a live demonstration of the hips right now. And then we can take a break for dinner after that.
The patient is being anesthetized and prepared and ready. Last. So, Sheetal, what are indications for hip spine fracture? We see a lot of young children, 3 and 4 years, being treated with lanes nowadays.
Uh, Usually, those between the ages of 6 months to 5 years, there's kind of the guideline. But we have widened the guidelines, if we think that the patient is a little bit, bigger weight-wise, size-wise, if the fracture sometimes it's really unstable, and we think that uh, they have a skin issue or they might have a skin issue. We can't rely on the parents very well to maintain the hygiene. And those are the patients that, even if they are 4, we would sometimes indicate them for dating. But typically, kids between the age of 6 months and 5 years. Before 6 months, they can be treated with polycarpus. After 6 months and about up to 5 years, typically a hip spiker. The other indications are obviously post-op. We use spikers quite a bit. And then vertebral fracture typically is treated close to the hip spiker.
Let's go ahead. The patient, we have a doll to demonstrate this method, and that has been placed on this hip spica table, which has been designed by Dr. Paulin Shah.
So the first thing is positioning of the patient. Usually the arms are on the side, on the armboard, and we want to make sure the patient's head is well supported. We usually put a towel on the patient so that when we are applying the cast or when we are trimming the cast, nothing falls on the fat that goes in any of the in tubes or anything. So we cover the face. We start with a stockinette. We're going to use this instead of a stockinette. There are different options of what you can do. You can put a liner, which is a plastic liner. It doesn't make the cast waterproof, but it does help to prevent soiling of the cast in case there is an accident. So using a liner is helpful. There are a lot of different things that have come out. We have waterproof cast. We have, cast that now we have a splint and a cast combination. But I'm going to just show a traditional single leg spiker. Single leg means that you put a spiker on the leg and it has been bent. We can use it for most of the low energy femoral shaft fractures. If you have a high energy fracture or very proximal fracture, you may have to extend to the mid thigh on the other side, which is called 1.5 spiker cast. Usually for fractures, we don't put a double spiker cast. That is typically used for post-operative, like if you have done a birth surgery or if you've done an idiot surgery that might need control of the pelvis and you need to put double spiker cast or double leg spiker cast. So I just want to show you the principles of putting a single leg spiker cast. So once you have your stocking, the second thing you want to make sure is that you have adequate padding underneath the stocking, because once you start wrapping it, once the patient is in this position and you put them down onto the bed, then there could be compression on the abdomen or on the chest. So in order to prevent that, you take maybe a sheet, either a stack of towels or a small sheet, and maybe we can use this here just for demonstration purposes. So we just put it down underneath the chest here, and it's okay if it's a little bit bulky or a little bit bigger. There is not a problem as long as you can. So this might not fit adequately, but this is in principle in stockinette, and we put something underneath so that you don't accidentally tighten up the cast so much that you're going to get chest compression or what is the name of the syndrome that you can get with the animal if you put a tight SMA or superior mesenteric artery can get compressed. So you want to be careful about it. So once we do that, the other thing I do is, the bottom part of the stockinette and the front part of the stockinette, I would usually pin them here to make sure that when you're putting the cast, you don't accidentally drop or touch the cast to the skin, because when you're using fiberglass, the material is very sticky. It's very difficult to get rid of it. So you want to make sure that everything is covered on the patient so it doesn't touch the skin. So we would take the top and the bottom part of the stockinette and then come together and put a pin here. That is the initial part. Then the second part, once you're positioned, once you're happy with the position, is your cast padding. So you want to make sure that before you start padding it, you are in a position which you like. You don't want to change the position after you start putting the padding, but before that. So usually, depending on the level of the fracture, you can change. Like proximal fractures need a little bit more flexion at the hip joint. A little bit distal fractures would need less flexion. But typical position, if you want to remember, is 30 to 40 degrees of hip flexion. So you flex it, 30 to 40 degrees of abduction, which is a little bit difficult to do on this model, and then a little bit of neutral rotation. Now, the amount of flexion you have at the knee should match the amount of flexion you have at the hip, so that your hip and the ankle should be in the straight line. So if you flex this more, then you need to flex this more so that it is in straight line. Otherwise, your leg would be hanging up when you put the patient down. So make sure that your knee and hip flexion angles are almost the same. Make sure you abduct 30 degrees so that you can have some hygiene, room for hygiene. And then you also need to put it in neutral rotation. So once you do this, you can check with the C-arm at this point to make sure that you're happy with your reduction. But most of the time, I don't check it at this point. I do my preliminary cast, then I check it, and then I would mold it and then complete the cast. So we'll just get started. We want to make sure that here the cast extends up to the nipples. Okay, so that's kind of your border where you start wrapping it. At every time you have the edge, you need at least 4 layers of soft roll to prevent the cast from pinching the skin. So at least 4 layers is what I would recommend. So you are starting like this. So 1 and 2, 3, and then a 4th layer. And then you just kind of, do half or 1/3 overlap. You don't need to put too much of material here. So this is for the torso, and then we can come and start winding around the hip here. And it's better to have, more assistance is better for these things. Just like even needing a femur fracture, I usually ask for help. I want 2 people to help me with needing a femur. Never shy away from asking for help. Don't try to think that, I can do it all by myself. It's for better patient care. It's better to have more help. Someone has to hold it and not do 2 things at the same time. The person who is holding this has a responsibility to just hold it in the position you want this to be held. So once you do your initial roll, and you remember that I said you need to put 4 layers at the edges. So here I'll use a smaller size, usually a 2-inch for the foot here. I don't think we have a 2-inch, so I'm going to show it, but I'll have at least 4 layers at the edge here. So I'm going to wrap it about 4 times here because I don't want the edge of the cast to pinch against the toes. So that's one. Second now is to reinforce the areas that are very common to have sores, okay, or to have breakdowns. So one of the areas is the heel. So I'll take these and I'll just cover it and make like a few layers, like 3 or 4. I'll put it at the heel so that we don't have any issues there. Similarly at the malleolus, which are the bony prominences, I'll make sure that I have a couple of layers around the malleolus extra, like this here. Same thing at the femoral condyles here. I'll make sure that we don't have any impingement of the cast against the femoral condyles. I'll put a layer over the condyles like this. And then the most vulnerable part of the cast where it frequently breaks is the groin. That is where the cast would break. So I'll make sure that I've got some padding here as well, because I'm going to put some extra layers of fiberglass here. And then the other thing is you need to check the back side of the cast, because this is called an intern's triangle. That is where a resident or intern would miss putting the cast on. So you sit down, see that area, and you put a few layers of this right in the triangle where this part meets the torso part, and you just pat it like this, because you don't want the cast against the skin, so you want it to be covered. So once I have this, then the next thing I'll do is start with the fiberglass. Now a few things, what you don't want to do is to put a below knee cast and then pull on it to get reduction. Okay, that is the thing you don't want to do because that would lead to a lot of issues. Once you put a below knee cast and pull on it, you're going to have pinching of the cast against the popliteal space, and you can get compression of the artery, compression of the nerve here. You can get an ischemic contracture. You can get some issues with the skin. So don't do that. If you want to, you can either start from here or from here. That's okay, but don't start as a below knee cast so that you can apply traction and reduce the fracture. That you should not do. The other thing you should not do is what is called a 90-90 cast. It was popular at one time to put the cast like this and bend it like this so that the patient can sit properly. Okay, but that is again leads to a lot of compression here in the groin, a lot of compression here in the popliteal fossa. So 90-90 cast, you should not do it. Okay, it's better to keep it in a functional position, 30 degrees. And a single leg spike would suffice, and this, most of the patients are very comfortable, and it's very easy to take care of their diapers and everything with a single cast. Now, the next thing you do is you're going to start with the fiberglass. We can start, as I said, we can start up at the torso. One of the keys is to leave about 1 inch between your edge of the cotton roll and the end of the fiberglass, so that the fiberglass should never cut the skin. So you need to have about 1 inch of padding. You can put more excess padding and trim it afterwards. It's not a problem, but don't try to stop padding after you put the fiberglass. It's better to just have over coverage and then trim it afterwards. So let's start with the 3-inch. Is this the 3-inch fiberglass? So you have bigger ones. You have 4-inch here. We can use 4-inch. You dip it so it gets really well soaked. Start putting your spike on. It's because you have so much of padding, as well as you have this layer in underneath, you cannot tighten this more. That means it's very difficult for you to then have excess compression. So you can be confident that you're going to be fine because you have so much of padding. You just wrap it. Again, the same philosophy of having enough padding at the edges. And then once you reach this area, that is when you start doing your figure of 4 rows. So I'll come here and I'll gradually start to come around the. You can give me one more.
Sheetal, do you use rolls or do you also use slats?
So first we'll do the rolls. This is just a preliminary cast to reinforce. I'm going to do some slats later on. I'll just put this one here, and I'm going to check and make sure I like my reduction before I do my reinforcement of the cast as well as finishing the cast. So my assistant is holding everything in position, and I'm just going to go ahead and finish this cast. I put a couple of rolls like this really quick, and then I check under fluoro to make sure that I like it. I'll take one more, please.
In all fracture cases, you do a direct this soft cast, or you apply first some plaster of Paris, one layer plaster of Paris, and then you apply this cast.
No, we directly do the
It's
fiberglass.
not needed actually, because the property of plaster of Paris and this is completely different. We used to do it earlier, when money was an issue, or your moldability was an issue. The 2 ends were a problem. But now I feel that if you just apply directly this, it does not really make a big difference to number of bandages you end up using. And the removal is difficult. Once you put plaster of Paris and this on top.
Yeah, and at this point, I'll get the CRP in because the cast is still soft, so I can manipulate it a little bit. You don't want to change the position at the joints because otherwise you can create some really deep creases that can pinch. but here is typically a mold. This, what I would do is I'll give a valgus mold for a femur fracture. The common patterns of displacement for femur fracture is varus and procurvatum. So you want to make sure that I mold it appropriately into valgus when I'm doing this, and I check it, and once I like it, then I would reinforce the cast. So just imagine that we are about 4 or 5 minutes into this, and you can get a mold and you're happy with the mold. Then it's a matter of how do you reinforce the cast and how do you complete the cast. So reinforce is just reinforcing the areas which are weak, which are typically the areas at the joint. So you want to make sure that you do some figure of 8 like this, come back so that you're overlapping it. So that's one way of doing it. Same thing I would do with the slats. So can we open up a 3-inch, please? I don't think. That's okay. That's okay. We frequently combine different colors as well. If the patient wants, we usually give them a choice of 2 or 3 colors. The patients really like this colorful, cast and one with the design. So the next thing is to reinforce. This is the weakest area right here. So what we do is we make slats. So slats are made like just like maybe 4 or 5 layers like this. Okay, and then I drop this right into the groin area here and into the back like this, and then I would continue doing the casting. So I want to make sure that that covers the triangular portion in this, and then I continue with reinforcing. So that's the slat at the back part here. You make a little bit longer slats, so once you drop it, it comes up to the buttock area here, and that would reinforce to make sure it doesn't then break in this region. So just for the sake of time, I will just dismount the patient after this, but typically you wait a little bit, let the cast dry so that you don't lose your reduction and you don't want a weak cast. So once you reinforce it with the slats that I showed you and some areas where you want a little bit more fiberglass, once you like it, then you dismount the patient at this. So dismounting is that depending on the type of the table, you'll have to see how you dismount it. But to make sure that the anesthetist is holding the head and you are holding the patient and your assistant is holding the leg, and then you put the patient down on the bed. Okay. All right. Once you have the patient down, you want to make sure that you see the hip and the ankle are in line so that it should not be like this with the patient lying down. Okay, once you have the hip and the knee at the same angle, the ankle would be touching the floor. Then you remove this part that you had put previously. Okay, so now you see that you have so much of space, you should be able to pass your hand very easily through the cast. So then you don't risk having, any compression. Now at this point, what you would do is, for the finishing part, once you take a cast saw and trim anything. So here you need about 3 to 4 finger breadths here. So you put your fingers, and if you don't have enough clearance, then you trim the inner part of the cast using a cast saw. Same thing in the back part. If you see that there is a part of the fiberglass that's going into the groin area, then you need to trim that. So I would typically draw some lines here, which part I want to trim, and then with a cast saw I would trim. Once you're done with the trimming, then just imagine that this is a stockinette part here. Then I'll fold the stockinette onto the edge here, so the carton would come like this, which would make the edge soft. The stockinette would come on top of it, and then I would take another fiberglass and I would put it on top. So can we get one more fiberglass? Same thing. Yeah, same thing I would do here. So for example, here you can see the stockinette. So what I would do is I'll take the stockinette and I'll fold it like this. So you see the stockinette, when it folds with the cotton. So you have stockinette, you have cotton, and you have the fiberglass. But when you fold it like this, you have a really smooth edge because now you have cotton between the edge of the fiberglass and the stockinette. So I would do this. I'll start at the bottom. I would do this, and I'll start putting my one additional, and this is just 2 layers. You don't have to put the entire fiberglass again. Just 2 layers to hold it in position. So we raise this here. So I just put a couple of rolls here to hold that edge. So now we see that we have a really smooth edge here. Okay, and then you can cut this, or you can just go up. But this is what I want at every edge. I want this kind of finishing, finish cast. And you can touch it afterwards, and you can make sure that it's not sharp, and then it's really soft here. So I would do the same thing after I've done this. I would do it here. I would remember I said I would put a pin here. So I would take the pin apart. Now I would roll that stockinette over, okay, like this. And on the top, I would do this, same thing. And then I'll put this roll on it. And so that way I know that I've got a really smooth edge here. Okay. And then once I've done this, we also have some tapes. They're called hyperfix tapes. They are like hypoallergic tapes. And the tapes are meant to keep the cast in place. You don't have to use it. We put tapes here and here to keep everything in place. And that's just like giving an extra layer so that the cast, everything remains intact. So that's about it. I don't. We have some videos that you can watch, on Umeri or any of the platforms, I think. But you just be consistent the way you do it. If you do it a few times, you get a feel of it. It's important that you reinforce the cast with the flat so it doesn't break. It's important that your edges are smooth. Important that you have about three fingers of clearance here. On the bottom side here, you want to make sure it covers 50% of your buttock here, so your neutral line here. You see that this is excess, right? This is your perineal fold. This is too much. So 50%, so if this is the buttock, your cast should only cover 50% of the buttock. So with the cast saw, at this point, I'll trim it like this so that you have enough clearance. And so that is also important. We usually would not flip the patient prone, but we would put the patient on the side. And then we would trim it across like this and then put the patient supine and finish that thing. So it's really important that because this is not acceptable, even though we place it, there is going to be cotton underneath here, so it's not going to be on the skin, but even then it's too much, it's excessive. So we would trim this, but not, if you go beyond 50%, you would significantly weaken the cast. So you don't want to take off too much as well. And that's about it. Are there any questions?
It's a wonderful talk, wonderful demonstrations. Any questions? So, what are the common complications you faced after hip spike applications? You know that, but what is the commonest you faced?
Mainly related to skin issues, especially if the patient is young, like 2 or 3 years old, then they're incontinent, they're not trained, body trained. So in those cases, I use the liner, the plastic liner I was talking about. It's just like a pantaloon thing that, you wear it, just a single layer of plastic underneath this whole thing. That helps to not get skin, soaked in urine or something. It helps to wipe off everything because it's plastic. You can do it. Otherwise, you can imagine you have cotton here, you're stockinette here, and all of them retains moisture. So it's important. The other important thing is to double diaper this kid. One diaper is, underneath here. So you put a diaper, stuff it here on all the sides, and then you put a diaper on top of it, and then you use a Velcro strap. So we always teach them how to double diaper the patients, because it's important. If this gets moist, then it's going to stay moist for such a long time. So we have seen skin issues, patients coming back because it's soaked, smelling bad, skin issues. The other thing is the education to the family that this is not a waterproof cast. There are liners that can make the cast waterproof, but you need to let them know. We had one patient where we had mentioned that this is not a waterproof cast, but the nurse on the floor thought that because we used a lot of waterproof casts and she was new and she thought this is waterproof, so she told them to wet it every day. And when the patient came back at the end of 3 weeks, she had mold underneath this cast on the skin because it retains water and you get fungus. So be careful, how you educate the families, about taking care of it.
How do you manage the breakage of cast during treatment? The patient spica get loosened, spica broken at this point. So what do you do?
So I would use more slats, like I made it, but I would make some slats with the 3-inch things, and I'll put it and I'll further, do it again. Very rarely, even at this point, say I don't have it's falling into wears right now. I'll just take this off from here to here, open it a little bit more so it's valgus, and put a small wedge to reduced. Shortening is not a problem because in kids up to 2 centimeters, they can, tolerate. They're going to overgrow once the fracture is healed. So usually 2 centimeters of shortening is not an issue. But you don't want to have them go into too much of varus or protoportum. So you can wedge the cast to get the reduction that you need.
So any questions? So thank you very much, Bhai, for a wonderful CME. I thank all the team of Cincinnati Medical Center for a wonderful sharing your experience. Thank you all delegates. Thank you VCT. So we go for a dinner. So dinner is the ground floor, right? The parking area. Kindly guide us. Thank you very much.